Bismillahirrahmanirrahim. Assalamu alaikum. Welcome everyone to a special edition of Tabadlab Live. Today, we're talking to Dr. Muhammad Ali Chaudhry. Dr. Chaudhry is the author of Tabadlab's latest working paper, which is called Shaping 21st Century Public Health in Pakistan, an actionable agenda for achieving universal health coverage. Dr. Chaudhry is the co-author of this paper along with Amara Khan, and we're very proud and very pleased to be able to talk to him and for him to have been able to, along with Amara, to have worked on this paper. Dr. Chaudhry, let's get right into it. By way of introduction, of course, you are currently in Saudi Arabia. You are working with the Saudi Ministry of Health, and you're helping support the leadership of the Makkah province in not only dealing with the COVID-19 pandemic, but in particular, managing the preparation for the Hajj season. This is a unique Hajj. I think there is nobody alive who's actually experienced what is going to happen over the next few weeks. And so for you to take time away from kind of your day job to have written this paper, is remarkable. And of course, I know exactly how long you've been at it. But just walk us through before we get into the meat of the paper, the process of putting the paper together, and what that experience was like for you.
Sure. First of all, thank you very much for this opportunity, and it's been a pleasure working together to highlight an issue which is very pertinent, both in the times of pre-COVID, and now COVID has only reinforce the concepts that we are highlighting, which is the nature of a healthcare system in a developing or an emerging economy. It's not as bleak as people will portray. Definitely it is challenging, but there are examples and successes that can be emulated and adapted to our local environment. So putting together, it's been quite an experience to first understand the healthcare landscape in the country, which when you are from the country, you typically would assume that you would know it, but it took a much more, in-depth look into the system, see how the system operates, and what are the challenges they face to better understand and better be able to provide solutions or suggest the action items. Because if they're not embedded within the underlying realities, then it becomes another policy which is disconnected from the ground reality. So that was the first part. And then second part focused on the solutions which have been exercised in countries with similar economies or had similar economies at some point, or regions within those countries that had a large population, which can be taken as an example and extrapolated to a large population. So that was the second half, focusing on the solutions. And COVID situation only reinforced that once again, in terms of what is the criticality of having a robust healthcare infrastructure in place. And it's not all about building new systems, it's also about redesigning and looking at the existing and highlighting the strengths already existing in the system.
I mean, this has been, of course, this has taken a while. And, we first spoke about this paper, which, is on the screen right now for our viewers. And obviously they can find it on the Tabadlab website, download it and have a look through it. When we first talked about you writing this paper, I think there was a substantial amount of lack of focus, and I think over a period of time, we were able to develop that focus. You, of course, are a trained physician, and you also have training in public health. You were the head of Saudi Aramco's health efforts for several years, and you also have worked in private equity, leading a private equity firm that was focused on healthcare. Why the interest in the public health system in Pakistan? What was the trigger for this? I mean, of course, being from Pakistan is reason enough, but in our first meeting, I was struck by the distinction between the needs of a country like Pakistan from the perspective of tertiary care versus primary and secondary care. Just walk us through that distinction and why that distinction is so important and why it's central to the framing of universal health care that you've presented in this paper.
So, first of all, I would go back to the journey being a physician, trained, studying in Pakistan, and then going to the United States and training in one of the premier institutions, and then returning to the Middle East. So that journey kind of highlighted some of the challenges and issues you face, and also elaborated that some of the underlying challenges are not unique to a country like Pakistan, which is in a developing state at the moment. The underlying issues can be the same. The scale of issues, the severity of problems can be variable across board. So that was my first sort of revelation, which I had when I went through systems and being in the Middle East for about 10 years now, only highlighted it further for me. So that was one. Second is I've always looked at Pakistan, and especially for the last couple of years, focused on Pakistan as not just because I'm from the country, but as a potential market which has huge growth potential economically and otherwise, and which can poised to become one of the lucrative markets, so to speak, from a private sector perspective that is untapped, and it's been difficult to understand from an outsider perspective. So that was the second impetus for me to look closely and deeply into it and better understand that what are the opportunities and what are the challenges we are facing, so that we can understand the challenges, devolve that into fragments and smaller pieces, and then address, kind of rebuild the whole system back. So that's the approach that I've developed since we first discussed, and based on the interest I've had in Pakistan as a market. So that led to the evolution and the context of what needs to be done and how it needs to be done as well. That's where the first half is have a clear focus on describing the existing system, not just the problems, but the infrastructure as it is, the demographic features. So you're framing the problem that you're trying to deal with, which is the population dynamics, the disease demographics being changing, your economy is growing year on year, and you are spending money, small or big, that's the second question, but you are spending money, whether in the public sector or private sector, that has been fragmented, and that has not been able to create an impact as we would have anticipated. So all these factors helped shape the thought process over the last couple of months when we started formally looking into this issue and framing this policy paper.
What is you mentioned the demographics and the changing nature of disease in Pakistan. What are the demographics? Just talk us through what is changing in terms of disease and where the priorities of policymakers should be in terms of public health.
So first and foremost, when you look at the disease demographics, there is a public perception which exists anecdotally that we are still in the phase where we have waterborne or infectious disease burden more than the other ones. But when you look at the literature and the data that has been published in the government sector and in the academia, it is very clear and in line with the trend for other emerging and developing economies that the disease burden is shifting now. It is no longer predominantly infectious or waterborne disease. The lifestyle disorders are taking a center stage as well, and they've been growing over years. So right now, currently, if you look at Pakistan's profile, the disease burden from lifestyle disorders is almost taking 50% of the load. So this challenge is coming across all emerging economies, and it is an issue which has an impact beyond the health of the people, because it affects the health of the community, health of the nation, which has an impact on the economic output, which has an impact on the social structure and so forth. So that's why the impact is far-reaching than just about getting better or making sure your health is okay. So that's the first change that is coming in the disease.
But just on that, before you continue, Dr. Saab, has the COVID-19 pandemic caused you to pause and rethink this demographic shift or the demography of disease shift? I mean, I understand what you're saying, and clearly, as readers and viewers will see in the paper, what you're saying is borne out by the numbers. But isn't it true that COVID-19 is in some ways kind of, reintroduced the idea of the killer, pandemic that is essentially an infectious disease? I think just clarify for listeners and for me as a layperson why we wouldn't continue to focus on infectious, especially in light of COVID-19.
Mm-hmm. Sure. So when you look at COVID situation and the COVID pandemic, it has an impact. Yes, it is an infectious disease, but born out of a viral origin rather than a parasitic or bacterial origin. So that's one of the differences between this. The second is when you look at pandemics like these in the history, I think as we progress and as the globalization and the mobility has increased, we have seen the issue has been the spread has been so fast that the system is obviously not able to catch up with what is happening. So that goes back to, again, looking at the demographics. And when you look at your lifestyle, then you have the infectious disease, which is mostly focusing on parasitic and bacterial infections. Then the third pillar is appearing, which is these pandemics, these viral epidemics that are going to, and we anticipate that it's going to happen again and again because of all the reasons we mentioned. So it does not shift the focus away from the underlying core feature that the balance between the lifestyle and the infectious disease is tilting. The lifestyle disorders is increasing and taking a center stage, which used to be peripheral. So the COVID and anything like pandemics like this highlight the third component. One is obviously the viral aspect, which is the origin. The second is the system capacity, which is in terms of an acute response, a short-term, mid-term response, and a long-term challenge, which again goes back to that because of comorbidities of lifestyle disorders, the mortality becomes higher for these issues. So that's why your focus does not change fundamentally. You still need to focus on building the infrastructure that is capable of these kind of issues and many more to come. So that's why the underlying the suggestions, the policy recommendations we are making are also taking into consideration to build a system that is able to deal with not just what we know, but what we don't know as well. That's coming our way.
Sure, and I mean, again, there's a lot of speculation and a lot of assumptions about what the future might hold in terms of this kind of a killer disease, and what the system should do to prepare itself for the eventuality of for this crisis to continue for a much longer time than originally thought, and B, I think maybe even more importantly, to be prepared for the next one. Some people are going to ask the question, which I think is a fair question, is does your paper and the recommendations in the paper, do they cater to or address, the basics of a healthcare system? How many beds, how much oxygen, how many vents, kind of, CPAPs? What is the net availability of critical care across the country? Will what you are suggesting end up increasing or beefing up that capacity, or are you headed in a different direction?
Mm-hmm. So if you look at the disease continuum of care that we provide, at one end of the spectrum is preventive care, which is to foresee and address the issue before it happens, all the way up to the curative aspect. So that's the paradigm we're always working through. The issue of COVID or anything of that sort, if you look at the resource shortage and so forth, the issue has been, which is we highlighted in our paper as well, that there has been focus on centralization of curative services in large setups in large cities, so which is ineffective to begin with. So the COVID sort of unmasked that on a very short time span again, that how ineffective that system is when you build larger facilities, focusing only on the curative aspect in an urban area when you're 60% of the population is not urban and living in areas. So you have created that problem of accessibility, problem of the quality, the problem of
So this
how
is a
you're going
really
to.
key point, and a key aspect of what you're proposing, and I do think it will jar a lot of, again, lay people who have a certain understanding. But what you're suggesting, and I want to get this right, that's why I'm asking you to clarify. What you're suggesting is that the heavily specialized tertiary care sort of hospitals or centers, that those are A, very high cost, and B, they don't cater to a wide enough spectrum of Pakistanis given the disease demographics of the country. Is that right?
Absolutely. So you are building these large infrastructures when you don't have a mechanism to have a prevention and primary and secondary screening in place, and everyone is accessing the same tertiary care hospital that's built. So the variability in the care that you provide in these facilities make it very difficult, makes it challenging at times. The cross infectivity, which will become a reality, is an issue with these things as well. So and I'm not talking about just to not demeaning the aspect of disaster management. That has to happen. That has its own place. We're talking about from a policy in terms of how the system is going to move forward as a whole. So when you look at the data and from Pakistan and disease demographics and the nature of problems, 80% of your problems are of primary and secondary care nature. So you've built these large hospitals which are focusing on tertiary care curative paradigm, and your patients are of primary and secondary care nature. When they access the system, what is going to happen? It's a mismatch between what is the reality and what is being provided. There is a place for those tertiary care hospitals, no question about that. There is a place for that. But the quality of care can only be improved when you have a system in place where the preventive, the primary, the secondary, that continuum of care is addressed closer to where people are, and address them and engage them and have a solution which is very pertinent to the local environment as well. So that is needed in terms of the focus of moving away from building these large hospitals, because in the same, and that was my earlier point, that it's not about that everything is right or wrong. It's about how you're going to spend that money. Even though it's a small amount, 1 to 2%, 3% at max of your GDP, but how you spend it is also going to make a difference.
There's obviously political rewards associated with the establishment of large specialized hospitals, and also kind of the home run hitters from a profitability perspective. It's not particularly profitable from a margin perspective to have preventive care. What a doctor is going to do? They're going to advise on what an ad should sound like in Pashto versus Bravi in terms of preventative measures,
Yeah.
which is a very different deal from quadruple bypass surgery, which is kind of relatively more common, but is a tertiary care thing. So in terms of the incentives, I mean, you talked about the private sector, and you said yourself that one of the motivations for thinking about public health in Pakistan is the economic opportunity for people with capital. But wouldn't the flow of capital follow the high margin areas of public health, which happens to be tertiary? So how do we square those two things, and what is the instrument of regulating or fixing it so that you have enough investment in the primary and secondary facilities that are smaller, more accessible? How's that actually going to happen given the profit incentives and the way they're structured?
So you're absolutely right. When you look at it from a private sector perspective, the shareholders' needs are also needs to be addressed. So that's where the role of the government becomes critical in terms of how they are diverting the resources and how they are creating policies that are going to support the involvement of private sector, not focusing on what is just available, curative, high-end tertiary, but also make it rewarding for them in terms of primary and secondary care, Because remember, at the same time, yes, curative is high margin and high profitability, but the primary and secondary care setup is also cost effective as well. The initial investment is smaller as well. So you can create smaller units with the same amount of capital that you're going to deploy for a 200-bed hospital by creating 10 smaller hospitals closer to where people are and able to address their primary and secondary care issues, which is actually, if you think about it, that case or that secondary care, which has margins as well, is currently coming to a tertiary care facility. So the government is losing money on both sides. They're spending money to provide an infrastructure. So that's where the government's focus in terms of how they allocate their resources becomes the incentive for private sector. Because what private sector is asking for, or what is going to look for, is what? They're going to look for stability. They're going to look for consistency and continuity of policy, because healthcare cycle of investment runs over 7 to 10 years typically. So they would want to have a continuity so they can reclaim their deployed capital and the efficiencies they built and so forth. And the government can incentivize them by getting into the things we mentioned in the paper, like strategic purchase program, where government doesn't have to provide that facility. They need to provide access. Government should not be concerned about just focusing on one thing, that my ability to provide healthcare is through building a delivery system. It could be through providing access, and then access can come through government becoming a more efficient and more prominent regulator at every level. Second is developing a level playing field for everyone so that there is no disadvantage. Third is building policies and purchase programs where they are incentivizing private sector to invest. So these are the things the government can do and should do and have been doing in some of the areas where they encourage the private sector investment. And then one example I would give, which a lot of people can relate to, is every time the government changes, you hear about these contracts that are given to run public hospitals, and the margins have to be created like next day. And typically within 6 months, 2 years, it ends up failing. And the reason is because the short-sightedness of thinking that somehow the private sector efficiency can override the culture that's prevalent in an organization within 6 months, and it's going to generate profit. The government's, the way they can support is, while they are doing this, do it at a longer cycle, and the government can develop the repurposing programs, because you need to continuously develop your healthcare workforce for the next level of care that they provide. So that can address some of the political backlash that everyone worries about when they are getting into these issues. So that's why with the government's focus shifting from delivery system to access, can provide that incentive and level playing fields for private sector to feel comfortable in deploying their capital over longer time period, and still be able to make margins.
Dr. Saab, I find, of course, I've read the paper, and of course, I would say that I find it fascinating. I hope that people will have a look at it, even people who are not specialists in the area, because it's been written with a view to explaining and laying out the challenge as it exists, the framework for how to address the challenge, and then the specific things that need to be done to meet that challenge. Just in wrapping up, Dr. Saab, what do you hope to achieve as an outcome of having written this paper along with Amara Khan?
So, the first and the foremost focus for me has been to start the discussion, to restart the conversation, and bring healthcare into the mainstream, away from this concept of, no, this is only something the government is going to deal with and they provide, and not realizing that currently the private sector is playing a major role in providing healthcare, but because it's not looked at as a sector, as an industry, where government sees an economic impact and an economic opportunity and leveraging that, it becomes a very redundant conversation of, no, this cannot be. So that's my aim, and my goal has been to restart the conversation, the discussion on healthcare in Pakistan, the opportunities, and giving a new lens to look at what are the existing challenges by going into the underlying realities and then linking it back to the solutions, and have a discussion around those so that people can see that there are solutions that can be implemented. They can be spanned over short to long term and so forth, and still can be a healthy industry, so to speak, that can have positive contribution to the economy of the country, develop new set of workforce, which is much needed across the world, and we can export it as we have seen other countries doing it. And the third is the ability to address underlying issues of health, which are impacting our economic progress by lost productivity and disease burden and so on.
Well, those objectives are not only noble but perfectly aligned with what Tabadlab wants to do. It's been a real pleasure putting this paper together with you and supporting that process for Amara and for yourself, and we're really grateful that you did it. Hopefully, we can take this conversation to the next level. Really grateful that you made time for us today, and hope you'll continue to do that, and also follow up with the working paper 6 or 7 or however soon you can get it to us.
Absolutely. It's been a pleasure working together, and I'm very excited to have this conversation and discussion around this topic. And it's an absolute pleasure for me. Thank you for giving this opportunity.
Good luck with your very important role out in Makkah. For any Muslim, what you're doing is God's work, and may Allah bless you and your team, both in terms of enabling you to achieve what you need to do, but also with safety and good health, so you could all get back to your families as soon as possible.
Thank you very much. Inshallah, and we're looking forward to it, for everyone to stay healthy and safe.
Inshallah. Thanks a lot, Doc Saab.
Thank you.